Hi, I'm Jeff Farnwell, Director of the MBA program at Rockford College. About 18 months ago, the Rockford Chamber of Commerce set out to make networking easier in Rockford by identifying area people you should know in business. Currently, 41 people have been recognized and celebrated as one of these people. This series of talks held at Rockford College was designed to provide a vehicle for the public to hear from and learn about each of the people you should know. I hope you enjoy this talk.
And welcome to Rockford College for our People You Should Know talk. Today I'm excited to introduce Dr. Bill Gorski from Swedish American Health System. There he is the president and CEO of that corporation. He is also a 2012 People You Should Know award recipient. Under Dr. Gorski's watch, the Swedish American Health System has grown to include the Heart Hospital, Center in Belvedere, as well as coming soon a cancer treatment center. Dr. Gorski is extremely involved in the Rockford community, sitting on a number of boards and councils. And his talk today will be on the healthcare reform. So please help me in welcoming Dr. Bill Gorski.
Thank you, Lauren. Well, I appreciate it. This is fun for me to talk about a topic with most of you who don't know much about it. That's really special because then I can say things and you probably aren't really sure if what I'm saying is credible or not. Also, I'm honored, Dr. Head, that you're here, of course, the president of Rockford College, and another one of the people you need to know, so you all know him, but another person that you need to know. I understand that Tim Knopf was here some weeks ago and perhaps talked about healthcare reform. I was not here when talking with Einar and John and others that perhaps his focus was a bit more detailed as it relates to some of the workings of reform as it might be affecting people boots on the ground, I would say. Now, that's an ambitious undertaking which I'm not going to attempt at all to replicate. For one thing, I think the boots on the ground implications are still evolving. I think it's very difficult in some respects to quantify what's going to happen with Medicaid expansion, health insurance exchanges. These are very, very complicated topics. What I'm going to do actually is take a step back and share with you my thoughts on why it is we're where we're at today. Now, some of this may be stuff that you've heard before, and that's okay, but I'm going to frame it for you in a way maybe that is a little different than the way you've heard it. I also am asked to speak not infrequently about reform, and I don't mind saying that in a very global philosophic sense, I am very much in favor of it. And the reason I'm in favor of it is because, again, at that macro global level, the path that this country has been on with respect to providing health care was a path of unsustainability. And you've heard that word over and over again about our healthcare system. You know, we live it at our organization, we see it all the time, and trust me, I don't think the word unsustainable is overly dramatic. And why is that the case? I have no technology today, I don't have PowerPoint, none of that stuff. And often I talk even without figures, but I thought you'd be interested in a few figures and facts. So the World Health Organization is an independent, apolitical organization which does studies, assesses data, and in the early 2000s ranked healthcare systems globally relative to, and the way they did the rankings is cost, quality of outcomes, and access. Okay, cost, quality, and access. In that ranking, the United States finished 38th in the world. Actually, France was first. And you would be shocked at the countries between first and 38th, but there's some that you would not think of as developed countries at all. Many of you have heard the data around the total cost for healthcare in America. And some of the most recent data is the total dollars per capita spent on healthcare in our country is about $8,000 per person per year. The next is Norway, which is $5,300, and they very rapidly fall off after that. As a percentage of gross domestic product, the USA spends 17.4% of gross domestic product on healthcare. Next is the Netherlands, which is 12%, and fall off very rapidly after that. Now, if you look at what are some of the outcomes of what we're getting for our dollar, because, you know, at the end of the day, this is why I believe strongly why you're seeing such a focus on reform as an economic development issue for our country. So when we spend something, obviously we expect to get something in return for it. So what are we getting for it? If you look again at those lists of developed nations, those that have economic systems of some stature, In the United States, we have fewer practicing physicians per 1,000 population. We have fewer hospital beds per 1,000 population. We have shorter lengths of stay in hospitals, which usually equates to a better cost structure, but not in this country. It's a higher cost structure. Just as a snapshot, in our country, though, what we have more of, and generally in the world stage tend to rank either first, second, or third in number of MRI units and MRI exams, number of CT scanners and CT exams, coronary angiography, total joint replacements, knees and hips, and C-sections. So we rank either first, second, or third in all of those, but we rank relatively low on number of doctors, et cetera, et cetera. I'm sure a lot of you have heard this data before, and it has been questioned, and I understand why it's questioned, but it's hard to ignore that the life expectancy in the United States of America is 40th in the world stage, Japan is first. In infant mortality, which is defined as the number of infant deaths per 1,000 prior to year 1 of life, the United States is 34th. You'd never guess who's first. It's Singapore. It's quite astonishing, really. So the way I think of healthcare reform is that the people who are writing the checks and paying the bill have gotten to the point of saying, we don't believe we're getting the value for the dollar we're paying anymore, and you, pointing at someone like me, you're going to need to do something about it. And we're going to force the issue through how we pay you for what we do. Okay? Now, I've talked about healthcare reform to groups of colleagues and physicians, and I have said to them, if we're very honest with ourselves, when I say ourselves, I mean providers of healthcare, I think we can say, shame on us for, I would say, 2 decades ago, not recognizing the path that the country was on with healthcare expense and the absence of the ability to quantify the value for that dollar spend. And the provider community didn't say, we better do something about this, or the people who write the check will. And we didn't. We didn't. We just kept percolating along. Life was good, reimbursement's good. You know, we're getting paid a lot of money for what we do. So we didn't do it. So finally, as there's a collision course with the amount of money being spent, and I'm sure every one of you in this room, no matter where it is you work, whatever your benefits are within your own, I was just talking to our HR VP in a meeting before here. We're going up 10% a year at Swedish American. I suspect many of you are in the double digits as employers, or even what you're paying for your health insurance. That becomes unsustainable, and it becomes an impediment to economic growth in this country. When President Obama was elected, what I have heard, it's kind of a little folklore story, is that a certain article published in the New Yorker magazine became required reading for his staff as they were contemplating steps in healthcare reform. I'm going to talk to you about it just a little bit. There's a very well-known, in our circle, a very well-known physician author whose name is Atul Gawande. Atul, A-T-U-L-G-A-W-A-N-D-E. And Dr. Gawande is a surgeon, and he is the medical editor of the New Yorker magazine. Well, in June of 2009, he wrote an article called The Cost Conundrum. And what he did is he went to 2 communities in Texas, McAllen, Texas, and El Paso, Texas. And what he found, now McAllen and I don't have a map in front of me, but they're not real close together, but demographically they're virtually the same. And when I say that, as far as age, gender, poverty, the distribution of all those factors that would roll up into demographics, virtually the same. In McAllen, Texas, now you may not know this, but CMS, which is what Medicare is, can tell you down to the zip code what they pay per year for a Medicare recipient anywhere in the country. They have all that data. It's extremely robust. So in McAllen, Texas, the cost of providing care to those residents was virtually double what it was in El Paso, Texas. And in fact, McAllen was number 2 in the country as far as cost per Medicare recipient, next to Miami, Florida. So Dr. Gawande got in his car and he drove down to Texas, and he thought, well, there's something going on here. I gotta figure this out. What's going on? So he visited McAllen and he visited El Paso, and he interviewed administrators, he interviewed physicians, and he tried to figure out what was happening. And it's a fairly lengthy article. It's very entertaining, but I can boil it down to this for you. My dad, rest his soul, used to say to me all the time, Bill, you get what you pay for. So what he would mean by that, well, is if you incentivize something, you're going to get this in return. If you incentivize X, you'll get X. If you incentivize Y, you'll get Y. In healthcare, we have forever been reimbursed based on how much we do, not the quality of the outcome of what we do. That's the way the system works. If you do 20 coronary angiographies, you get paid for 20 coronary angiographies, even if the evidence suggests you maybe only needed to do 12. Okay? So what was going on in McAllen, Texas is the utilization of services was extraordinarily high. And actually, this sounds very damning, but when Dr. Gawande got into how that actually was working, what he found is that in McAllen, Texas, there were a lot of physician-owned imaging centers, there was a physician-owned hospital. So there was a built-in incentive for utilization because the reward was there. People were paying for it. In El Paso, what he found is that those models didn't exist. There was a relatively large collaborative in El Paso where the physicians actually got together and thought through maybe what is the best and the most efficient and effective way to care for people in a way that eliminates and reduces waste. So two communities, almost exact number of population, exact poverty levels, demographic, age, sex, gender, everything else, double the cost in one. The other interesting thing is, I won't ask you in a quiz fashion, but, well, do you think the Mayo Clinic is high in expense per Medicare recipient per year or lower in the middle? Where do you think the Mayo Clinic is? Any idea? Lowest 15th percentile, the Mayo Clinic. Now, if you think of the Mayo Clinic, wouldn't we all agree, and I think the evidence would suggest this, that the quality of the physicians, the technology, the services, the outcomes, and to those of you who don't know, all those things are very, very good. They're very, very good. Lowest 15th percentile on the Medicare cost curve. Why? Well, you get what you pay for. You get what you pay for. If you were at the Mayo Clinic, and there are other examples in our country, there's Geisinger in Pennsylvania, there's Kaiser, there's Intermountain Health out in the West. There's a number of these examples where the physicians actually work together to really understand the care of individuals and populations of people to come up with the most effective way to treat someone. And they follow evidence in doing so. So there is an awful lot of evidence out there that informs providers now what the best way to treat someone is. Let me give you an example. I mentioned the MRI thing a moment or two ago. So someone, I can relate to this myself, who has back pain, let's say, for instance. In America, I would suspect we're at a far lower threshold to order MRI scans on people who have back pain. The evidence would suggest that unless certain things are present at the time of that presentation of those symptoms, doing so is not indicated. It's not indicated. But we do an awful lot of them in this country. We do an awful lot of them. And it's hard when the whole system has been aligned toward, let's say it's been, not only has it been aligned toward volume, but there have been disincentives in the system, or lack thereof, to promote quality of outcomes. So no one is saying, or has to this point said to us as providers, at the end of the day, we're going to begin recognizing in our payment stream to you the quality of what you've done as opposed to the quantity of what you've done. Now, as it relates to this current healthcare legislation that's there, again, philosophically, I believe that the direction is appropriate. And the direction is, embedded in all that 2,000 pages, is we're going to begin morphing the systems of payment into paying you for outcomes, not just for the quantity of what you do. I think that's really good because, as Dad used to say, you get what you pay for. If you incentivize quality, you'll get quality. If you incentivize quantity, you'll get quantity. Yeah. Do you know, this is, some folks find this very fascinating, if not shocking. It's only been the last couple of years or so in this country that the payers of health care have not paid us for operating on the wrong side of the body. So let's say if you came in and you were supposed to have a right knee surgery and someone made a mistake and they operated on the left knee, let's say, we got paid for that. Now, if you think about it logically, is that correct? Should that happen? I don't think so. I mean, I'm going to go stand here and be defensive of that. So, you know, I'm being harsh on my own profession because I've lived it for many years. I practiced for over 20 years. And I think the harshness is warranted. I mean, shouldn't we have been the ones who've said we should have certain measures in place to prevent operating on the wrong side of the body? But I'll be honest with you, we didn't do it until the payer said, we're not going to pay you for that anymore. Now we don't do it. We have all sorts of things. We have checklists in surgery. If any of you have had an operation, the surgeon will come by and use a magic marker and say, before you've been given the drug in holding, they have to do it before you've been given the drug. They'll walk and look at you and eye. It is your right knee, isn't it, Frank? Yes. Magic marker. That didn't happen until 3 years ago. We got paid for it. We got paid for it. Another great example going on right now, because people say, what are you talking about? Well, a real big push right now is to penalize us if individuals who are dismissed from the hospital come back in within 30 days. It's called a readmission. And all payers are, and I'm going to get to this in a second, all payers are doing this. So at the end of the day, around the country, since this has happened, the readmission rates for patients who've been dismissed, going home, coming back within 30 days, is constantly going down. Now I will tell you that's a good thing, because normally what it means is take an elderly person, an 85-year-old person with congestive heart failure who goes home and they have 20 medications and they're confused and their caregiver's trying to figure out what to do and they don't understand what's going on, and 7 days later they're bouncing back to the emergency room. That's not good health care. So now we and everybody in this profession has put systems in place to manage the care of that person so that that frail individual does not get confused, takes their medicine appropriately, gets a follow-up visit with their doctor. That's a really good thing. That's good health care. But we didn't do that. The payer did that to us. So I don't think we can, as a provider community, shake our heads and say, woe is me, we're being victimized here. I don't agree with that at all. The other thing that I also think is a little bit of a disconnect for some folks is because of the publicity, we tend to think that this is the government. This is primarily the federal level, the Accountable Care Act, Medicare. And I got to tell you that the private payers in this community, Blue Cross Blue Shield is the biggie. I have to tell you that the private payers are more agile than the government. They move quicker, and they are moving at least as fast or faster than any governmental payer can, because they can. And so all of these things we're talking about, so demanding of providers that you care for people efficiently, get rid of the waste, the same conversations, if not more intensely, are happening with Blue Cross than they might be on the federal side. So this is a real sea change of what's happening in our country, and I absolutely believe it has to happen. The problem with right now is getting from point A to point B. So how do you get from doing something that every single one of us in this room has consumed health care? It's a personal part of our lives. So none of us are detached from it, and we're talking about moving from point A to point B, turning this whole ship around. We've got private insurers who have a vested interest in things turning out a certain way. We've got the provider community have a vested interest in things, preserving compensation, preserving revenue, trying to figure out how to make it all work. You can see all these pieces on a collision course, but they are right now. They are colliding. And I don't know how else that happens other than the collision course occurring. When you're talking about blowing up something that has been working a certain way for a long period of time, but is, I believe, really broken. I think you also know that healthcare reform is nothing new. Presidents as far back as Theodore Roosevelt have contemplated healthcare reform. I read a book about Dwight Eisenhower not too long ago, who I didn't know much about. It's a great book, by the way. I learned a lot about Dwight Eisenhower. One of the things I learned is that he wanted to institute national health care. And you can see how far that went for him. It didn't go anywhere at all. But he was quoted as saying to his cabinet, "Why shouldn't everyone in America receive the same benefit I do by being a part of the military?" He couldn't understand that, but it obviously didn't go anywhere. So I'm going to make sure, I'm looking at the clock, make sure that you get out in time and have time for questions. But the other big part of reform that I want to stress for just a moment that I think is really important, and it gets to what I think Dwight Eisenhower was talking about, is the uninsured. So, by any count nowadays, there's probably north of 50 million people in this country who are uninsured. The Affordable Care Act was intended and modeled to impact about 32 million of those, so there still would be a fair number of people who are uninsured. So when I've talked with folks about this before, I do hear comments occasionally that no one in America goes without health care. Even if you're uninsured, you are going to get health care. And in a global and an emergent sense, that's true. But the problem with that, and given where Swedish American is at, and given the economy of our community, I think all providers in this community, there's a fair number of people who access the healthcare system at a point in that care continuum that is not a good point in that care continuum, where addressing their needs is far more costly than if they had coverage and they had access on the front end. There's numerous examples. The classic one would be the cold and bronchitis that is never treated that becomes the pneumonia that winds up causing the person to have a 4-day hospital stay and a bill of whatever. And in the circumstances of many individuals, for a provider like us, that is completely written off, 100%. There is no Medicaid, there is no insurance, there's nothing. And the cost of that to an institution like ours is in the tens of millions of dollars a year. So if there are two global philosophic points behind healthcare reform, what I take away from it is let's try and eliminate as much waste as we can from the system, drive the providers to provide evidence-based care, which is appropriate for the patient in that circumstance, and then let's cover the uninsured people so that they are not further a drain on the system financially, but also are receiving better care. So at the end of the day, that becomes an issue of access. So hopefully every one of us in this room, if we have something going on with us, can go and see a doctor. There are many, many citizens in our community who don't have that, that opportunity. I often say, and Gordon Eggers is grateful for me for saying it, but we should be thankful every day that Crusader Clinic is in our community. Because Crusader Clinic is a landing spot for so many. Actually, what Gordon would tell you is there's over 40,000 individual lives that Crusader Clinic cares for in this community. Over 40,000 people. And this isn't just people that you would think of as, if you do, profile, which I would hope you wouldn't, but if you would profile and say these are people who are somehow downtrodden or undeserving, that is not true. You will meet people who go to Crusader Clinic who are very deserving, who because of life circumstance and job loss and layoff and whatnot are now in a circumstance of being challenged. They enter into the healthcare system at times when you and I maybe could go to the doctor for something to prevent it from turning into something more. They at least have Crusader Clinic in many circumstances, but there's still many who don't. So even if we didn't necessarily approach caring for our fellow human being from an altruistic perspective, which some do, and I tend to be one of them. So let's say even if we didn't, if we only looked at the financial burden of caring for the uninsured, it is enormous in this country. And it's built into the cost structure of all of the payments that we all pay for health care, because it's built in there. It has to be. Swedish American, the other two institutions in town, we cannot continuously lose money, shock of shocks. Not-for-profit is a tax status. It's not a mission statement, is the old joke. But if we didn't, we couldn't do things like Lauren was talking about. You can't try and improve cancer care in the country. You can't do those things. So at the end of the day, you put it into the big stew pot and you mix it up, and you got some folks who pay, then you got the government who pays a lot less, and then you got a whole bunch of people who don't pay anything at all. And you put it all in, and at the end of the day, it's got to all work. So that, $200 bronchitis that turns into a $40,000 hospital visit for pneumonia is absorbed somewhere. So I think that the attempt to cover the uninsured is laudable. How this all will work out with the current law and what might happen, I think is unknown. The devilish details that we always talk about are truly there right now. And I think when you get into the kind of the wormhole of conversation of what's going on with health insurance exchanges, expansion of Medicaid in the state of Illinois, I talked to Senator Severson about that, I know how he feels about that. So these are the details where people scratch their head and say, okay, what he says I understand, but what's it going to mean to me? I wish I could tell you. I'm not sure yet. If we ever get to the other side, what we should have is a more efficient system where evidence drives a lot of decision making. There's collaboration among physicians to decide what's the best treatment plan for each and every one of us. Waste is eliminated, redundancy is eliminated, quality of outcomes are better, and those of us who do better providing quality are rewarded for that and how we're paid. You know, when you go out nowadays, I suspect if any of you want to buy a flat screen TV or a car, you're going online and you're doing your little searches and you're doing this and you're looking at Edmunds and you're looking at reviews and so and so. Will we get to that place someday? We're getting closer right now. We're getting closer right now where you may be able to tap in Swedish American and tap in a provider who does knee surgery and figure out what that doctor's cost is for that procedure, what their complication rate is, how quickly you return to work after your total knee joint, and it'll all be right there. I don't think that's even 5 years away. I think it's sooner than that. Let me stop there, and I'm looking at the clock. Lauren's giving me a real strict order. Let me just open it up for any questions or comments you might have, concerns of any sort, challenges.